Two different types of laryngoscopes is going to be the most painful word of the day. You have the one with the screen. I'm going to call it digital. I'm not sure what it's actually called. And then you have the manual, the McGill and Miller, not McGill, Miller and Macintosh, just like we've been discussing. Definitely prefer those because technology fails and I don't have the comfort of an ER room, an AC, and a respiration therapist and anesthesiologist, and everyone else that's circled around me. I have a bag of crap, and I get to pull out those tools, and I use those. If they fail, then person dies. The less likely they are to fail, the less complex that they are. Some video laryngoscopes require displacement of the tongue. Others are inserted in the middle of the mouth. Simply follow the curvature of the tongue. Certain video laryngoscopes allow you to visualize the airway structures and stop working. I really don't think this is popular, but this is, relevant, so I guess that's what they look like. Here you go. Nasotracheal intubation, insertion of a tube through the trachea, through the nose. We usually perform this without directly visualizing the vocal cords in the pre-hospital setting. Excellent technique for establishing control over the airway in situations when it is difficult or hazardous to perform laryngoscopy. Indications and contraindications. So we have responsiveness of patients. If they're responsive, we're not going to intubate them whatsoever. Patients with altered mental status, intact gag reflex, who are in respiratory failure because of their conditions such as COPD, asthma, pulmonary edema. Oh, so this is indicated. So they can be responsive for this. Interesting, didn't know that. Now I learned. Contraindicated for apneic patients in respiratory or cardiac arrest. Should be orotracheally intubated. Patients with head trauma, possible mid-face fractures, and patients with anatomic abnormalities or frequent cocaine use. Avoid patients with blood clotting abnormalities and patients in anticoagulation medications. So, if they're taking aspirin or heparin, I guess because if you make them bleed, now you can't stop it. Advantages can be performed on patients who are responsive and breathing. The mouth does not need to be open, better suited for patients with limited temporomandibular joint mobility. Does not require sniffing position, ideal for a possible spinal injury. The tube is inserted through the nose so the patient cannot bite the tube. Can be secured more easily than an orally inserted tube. Disadvantage, blind technique. So major tube conformation cannot be used, just like where you see the vocal cords and slide it in. We don't have that. Confirming the proper tube requires more diligence. Bleeding is the most common, so they'll get epistaxis, especially through with rough technique. Poses an additional threat to already compromised airway. Incidence with bleeding can be reduced with the gentle insertion of the tube, lubrication of the tip with a water-soluble gel. Anesthetic lubricant containing vasoconstrictive agent will reduce the patient discomfort and likelihood of severity of nasal bleeding. Equipment, the same equipment used for orotracheal intubation minus the laryngoscope and stylet. Select the tube that is slightly smaller than the nostril. Some ET tubes have been designed specifically for blind nasotracheal intubation. We have an endotracheal tube, so slightly more flexible than the standard ET tube, equipped with a trigger that moves the tip of the tube anteriorly and increases the tube's overall curvature. Equipped with a trigger that moves the tip of the tube anteriorly and increases the tube's overall curvature. I just read that. Yeah, movement of the air through the ET tube helps determine the proper tube placement. A number of devices allow the paramedic to confirm successful intubation without placing his or her face next to the tube. For technique, we have used the patient's spontaneous respirations to guide the nasotracheal tube into the trachea and confirm proper placement, right? So you kind of have a period where they breathe and it flares up a little bit. It's opening, boom, slide it in. Use that. Just like whenever you're driving your car and you're about to follow your friend into their apartment and the gate opens and you're trying to slide in, we're doing that. with the tube. After preparing the equipment and pre-oxygenating the patient, insert the tube through the nostril, bevel facing the nasal septum. The right nostril is typically used. If the right nostril is obstructed, we're going to insert the tube into the left nostril, but rotate the tube 180 as the tip enters the nasopharynx. Aim the tip of the tube straight back towards the ear. Do not insert the tube with the tip aimed upward towards the eye. Good to know. Aim the tip of the tube straight back towards the ear, but not up. Position the tube just above the glottic opening so that the patient will draw the tube into the trachea when he or her inhales deeply. We're waiting for that gate to open. Manipulate the patient's head to control the position of the tip of the tube and maximize air movement. Cup your hand if the tube is in the right nostril under the patient's occiput. Move the head up to achieve maximum airflow through the tube, and we're going to instruct the patient to take a deep breath and gently advance the tube with the inhalation. Placement of the trachea will be evident by increase of air movement through the tube. If you see a soft tissue bulge on the other side, then a bulge on either side, the tube may be inserted in the piriform fossa. Hold the patient's head still and slightly withdraw the tube. Once the maximum airflow is detected, advance the tube on inhalation. If you do not see a soft tissue bulge, the tube has been entered into the esophagus. Withdraw the tube until you detect airflow and extend the head. It doesn't say where. On either side of the airway. Okay, so I guess like this is your soft tissue, maybe here. That's your piriform fossa. Once the tube has been properly positioned, inflate the distal cuff with the minimum amount of air necessary. Attach the bag mask to the tube and ventilate. Confirmation of monitoring is extremely important. Clean up secretions, excess lubricant, and secure the tube with tape. Document the depth of the insertion of the nostril. To properly perform blind nasotracheal intubation, look at the skill drill. Digital intubation, that's using your fingers, involves directly palpating the glottic structures, and just reminds me of that Matt Rife joke that I just watched yesterday on TikTok. And elevating the epiglottis with your middle finger while guiding the ET tube into the trachea by feel. This gives you an option with some extreme circumstances. In most advantageous cases of equipment failure, primary disadvantage to require placing finger in the patient's mouth. If they have a seizure and they bite down, those are gone. Risk of being bitten and exposed to infectious disease. If they're a vampire, you might end up becoming a vampire if the teeth tear through the gloves. Perform only if the patient is deeply unresponsive and apnea and a bite block is used. If you have a leather belt, use what you got. Absolutely contraindicated if the patient is breathing, not deeply unresponsive, if they have an intact gag reflex. Major complications, misplacement of the ET tube. Technique, prepare equipment as your assistant ventilates the patient with the bag valve mask in 100% oxygen. Place the ET tube that is 1/2 the size or smaller that is used for intubation with the direct laryngoscopy. Tip the tube is guided through the trachea and index the finger is the leverage point. I got bit my cheek last night. 2 conformations are recommended. Open J configuration. The stylet is inserted with a large J shape that is made on the distal end of the tube. The U-handle configuration. Tube is bent into a U shape. Proximal. Half of the tube is bent into a 90-degree handle towards your dominant hand. Like so. So you have the J and then the U handle. I prefer the U. Sniffing position is not required. We're going to insert a bite block, a flange of the oral fairway between the patient's molars, and insert the index of your middle finger and left hand to the right side of the mouth. Press down against the tongue and slide your finger until you feel the epiglottis. Gross. Pull the epiglottis forward with your middle finger. Hold the ET tube in your right hand like a pencil and insert it into the left side of the patient's mouth. Advance the tube and guide the tip towards the glottis. Once you feel the cuff of the tube pass about 2 inches beyond your fingertip, stabilize the tube while you gently withdraw your finger from the patient's mouth. Carefully move the stylet and inflate the distal cuff 5 to 10 milliliters of air. Attach the bag mask device to the ET tube and ventilate while observing for visible chest rise. Rigorous protocol for confirmation of tube placement must be followed. We're going to auscultate both lungs and over the epigastrium. Monitor your EtCO2, your carbon dioxide, and properly secure the tube in place. Continue ventilations according to your patient's clinical concerns. Trans-illumination techniques for intubation. So tissue that overlies the trachea is relatively thin, so you could actually see it go in, I guess, if there's a bright light. A bright light source is placed in the trachea that emits a bright, well-circumscribed light. Yep, that's exactly the word they just used. A number of devices that is used to intubate the trachea with transillumination. We have the lighted stylet, describes the malleable stylet with a bright light at the distal end. Indications and contraindications, so it can be used whenever a patient needs to be intubated, but usually performed with other techniques have failed. I feel like this is useless info. What is the advantage? Visual parameter does not require visualization of the glottic opening. Sniffing position not required. Major disadvantage, proficiency of equipment. Your equipment's going to fail. Misplacement of the tube in the esophagus because the intubator cannot directly visualize the tube passing of the cords. Yeah, so even still. Device with a rigid stylet. Stylet must be long enough. I'm so over this. There's got to be more important info about the respiratory. Retrograde. Let's see what this is. Rarely performed in the pre-hospital environment, only in EMS systems where local protocols indicate. So a needle is placed precautiously with the trachea via the cricoid membrane. A wire is placed toward the head through the needle upward through the trachea into the mouth. The wire is devisualized and secured, and the ET tube is placed over the wire and guided into the trachea. The wire is subsequently removed and the ET tube is advanced and secured. Indications include copious secretions in the airway, failure to intubate the trachea, and less invasive methods. Contraindications, this would include lack of familiarity with procedure, laryngeal trauma, unrecognizable distorted landmarks, coagulopathy, and relative contraindication. Severe hypoxia due to the inability to ventilate during the procedure and time to perform this procedure. Complications include hypoxia, cardiac dysrhythmias, mechanical trauma, infection, increased intracranial pressure, ICP. Assessment and finding the transport complications are the same with the standard intubation. To properly perform retrograde intubation, we're going to look at these skills face to face. Oh, tomahawk method. That's what this is. This is tomahawk method. This is easy. Whenever I first succeeded, I did the tomahawk method. Tracheal bronchial suctioning involves passing the suction catheter into the ET tube to remove the pulmonary secretions. Requires a strict attention to sterile technique. Can cause cardiac dysrhythmias and the cardiac arrest. You're stimulating the vagus nerve. Avoid unless secretions are so massive that they interfere with ventilations. Must be performed. Use a sterile technique. Monitor cardiac rhythm and oxygen saturation. Pre-oxygenate for at least 2 to 3 minutes. May be necessary to inject 3 to 5 milliliters of sterile water down the ET tube in order to loosen up the thick secretions. We're going to gently insert the suction catheter down the ET tube until resistance is felt. Apply the suction as the catheter is extracted. Do not exceed 10 seconds in adults, as we've talked about. Field extubation, you're just ripping it out. No. So make sure you deflate the balloon, the pilot balloon, all the way, and then extubate. That's pretty much it. What risks do we have? Patient's inability to protect their own airway. Instead, sedate with benzodiazepine. Pharmacological adjunct airway management ventilation. All right. Pharmacological agents are used for decreasing the comfort of the intubation and to decrease the incidence of complications. Make aggressive airway management possible for patients who are unable to cooperate. Sedations and emergency intubation. We are going to reduce the patient's anxiety. We're just going to stop because I'm going to make this a whole separate video.